Okay, good morning, everyone. It's 10 a.m., so we're going to kick things off. Thank you, first of all, for everyone for joining us this morning. I think some people are still in the midst of jumping on, and actually, our Bangladesh field coordinator, Dr. Miriam Mola, has just joined. Welcome, Maryam. um, well, to begin, I'm Kat Fallon, and I'm the advocacy advisor at MedGlobal. And as many of you know, MedGlobal is an international health and humanitarian organization that works to serve communities by providing sustainable, innovative, and free healthcare services to refugees, IDPs, and other vulnerable populations in crisis areas and low resource settings. We particularly focus on collaborations with local health organizations, capacity building for local health professionals, and providing the most needed humanitarian and medical assistance. We've been on the ground in Coxs Bazar since 2017, and we've been honored to serve more than 100,000 Rohingya refugees during that time. And so that brings us to this webinar, which focuses on the health response during COVID-19 for Rohingya refugees in Bangladesh. As MedGlobal, we've provided primary care, emergency care for children, treatment for those with chronic illnesses, and we've also led trainings over the years in helping babies breathe, which is a critical resuscitation technique to reduce neonatal mortality, as well as trainings on how to provide trauma-informed care. And just this month, MedGlobal has planned a 4-week COVID-19 response training for field staff and developed an emergency triage procedure, all of which Dr. Miriam will be touching on more in a bit. So in the midst of this global 19 pandemic, MedGlobal, in coordination with our partners, is hosting a webinar series focused on the global health response for refugees and IDPs. As I think most of you know, there are over 70 million forcibly displaced persons in the world, and we know that they will be hit the hardest by the COVID-19 pandemic. These communities must not be forgotten. So our webinars have focused on responses for refugees and IDPs in Colombia, Syria, Greece, and now that brings us to today's webinar with a focus on Bangladesh. So as most of you know, Rohingya refugees living in camps in Cox's Bazar in Bangladesh have faced overcrowding, a lack of sanitation facilities, poor water quality, limited health care, and other quite dire conditions for years. And fears are now growing about the potential impact of COVID-19 for refugees in these camps. So this webinar is focusing on the overall situation facing Rohingya refugees in Cox's Bazar, updates from local medical clinics, projections for the virus impact, and key needs of health workers and local refugee communities. It's my pleasure to be joined by 4 incredible humanitarian and health experts. So we'll be hearing from Dr. Azim Ibrahim, the Director of Displacement and Migration at the Center for Global Policy, Dan Sullivan, the Senior Advocate for Human Rights at Refugees International, Dr. Miriam Mola, a physician and the Bangladesh Field Coordinator for us at MedGlobal, and Sean Truelove, who is an Assistant Scientist at the Johns Hopkins Bloomberg School of Public Health. So after we hear from the panelists, we'll open it up for a Q&A at the end. And I would encourage all of those attending to enter any questions that you may have in the Q&A box at the bottom of the screen or in the chat feature. And we'll be circling back to questions after the remarks from our speakers. So to kick it off, our first speaker is Dr. Azim Ibrahim, who's the director of the program on displacement and migration at the Center for Global Policy. He is also an adjunct research professor of strategic studies at the U.S. Army War College. And Dr. Ibrahim has a PhD from the University of Cambridge and has served as an international security fellow at the Kennedy School of Government at Harvard and a World Fellow at Yale. He's also the author of The Rohingyas Inside Myanmar's Hidden Genocide. So kicking it off to you, Dr. Azeem.
Thank you so much, Kat. and thank you so much to the team at MedGlobal for putting this event together. We are living in an unprecedented situation. Never in history have so many people, over half of humanity, had the same experience at the same time. And we are obviously all understandably focused on our own experiences and our own predicament. So it's actually a testament to MedGlobal that you are focusing so much of your effort on highlighting the plight of those that do not have a voice. I'm fully aware of MedGlobal's work and the stellar work that you are doing in the camps. And it's a testament to yourself, to your president and your new executive director who is doing this fantastic job. I'm fully aware that MedGlobal is looking at the refugee populations around the globe, but I want to take a few minutes of your time to try to explain to you why I believe that the situation of the Rohingya is very different from all the other refugee populations around the globe. But for me to do that, I'll have to explain to you how we got here in the first place and why the situation is extremely different for the Rohingya. The Rohingya minority has been described by the United Nations as the most persecuted minority in the world. This is a title that unfortunately many groups will want to claim. There's no shortage of groups that are being persecuted, but it's the Rohingya that we describe as the most persecuted minority. They're an ethnic minority group from their Rakhine state in Myanmar. They're the largest group. They have a different religion, a different skin color, a different language, so they were always different. But the persecution of the Rohingya started really back in the Second World War when the Japanese invaded what was at that time British Burma. The minority Rohingya population stayed loyal to the British colonial masters, whereas the majority Buddhist population supported the Japanese invaders, believing that the Japanese would be victorious and this would lead to swifter independence. After the defeat of the Japanese, there was bad blood between the two people because the Rohingya were looked at as the fifth colonists, as having not supported the majority Buddhist population. But despite that, there was relative calm up until 1962 when there was a coup by the military chief, General Ne Win, and he tried to implement a communist manifesto, which was a disaster. And he did what a lot of authoritarian dictators do in that situation, is that when things go wrong, they look for scapegoats. And the Rohingya minority, who were already looked at with suspicion, were the perfect scapegoats for this. So he passed a number of laws which culminated in the 1982 citizenship law, stripping all the Rohingya of their citizenship and making them the largest stateless group in the world. And since that time, they have faced wave after wave of violence, which culminated in the 2017 genocide when Myanmar decided to expel over 700,000 Rohingya refugees into Bangladesh. Now, I say this because unlike many other refugee populations, and I've had this discussion with a number of scholars and humanitarians, whether it's the Yemenis, whether it's the Syrians, and all of these people deserve the utmost support. The difference with the Rohingya is that when the situation settles, the Rohingya have really nowhere to go. Unlike the Yemenis, which hopefully the war is now coming to a close, at least the beginning of the end, the Yemenis will hopefully go back to Yemen. The same with the Syrians, the same with all other refugees. But the Rohingya have nowhere to go. They're completely stateless. They're occupying the largest refugee camp in the world, over 1 million of them in squalor and mud. A number of experts that I've spoken to have told me that if the COVID-19 virus manages to get into the camp, you're essentially looking at about 100% infection rate. Almost everybody would get infected because of the conditions of the camp. Now, this is one of the real challenges that we have, is that the Rohingya have really nowhere to go. Bangladesh is one of the poorest and most densely populated countries in the world. They are hardly likely to have any extra capacity to support the Rohingyas if the virus makes it into the camp and starts tearing through this camp. Most recently, we had the ruling from the ICJ, the International Court of Justice, which was essentially a caution, a warning to Myanmar to undertake particular action to stop the genocide against the Rohingya for the remaining Rohingya in Myanmar. But despite that, Rohingya are still pouring over the border. Hundreds of them are still pouring over the border. And most recently, in the last week, we've seen a situation in which over 500 Rohingya were trying to flee from Bangladesh. So this is the safe haven that they're in. They're trying to flee from Bangladesh on a rickety boat, 500 of them in a tiny little boat, cramped with human cargo. They spent 2 months in the sea, and they were eventually turned back from Malaysia because Malaysia is under lockdown. The majority of these people were between the age of 12 and 20, so very young. Over 100 died of starvation in the sea, and when the boat was actually found, the rest were absolutely malnourished. And many of the survivors, the legs were paralyzed because they were immobile for months. So even within Bangladesh, many are still trying to flee this safe haven. So the situation of the Rohingya is unlike any other refugee situation. I have travelled sometimes with MedGlobal to camps, refugee camps in Syria and elsewhere, in Jordan, Syria, and elsewhere. And the situation there is extremely different. All of these people deserve support. All of these people deserve the utmost attention. But for the Rohingya, there really is very little hope for them to go back to their home country, very little hope, very little prospect of them regaining their citizenship. So they really have nowhere to go. They're completely unwanted people. Some of my colleagues here on the panel will be able to talk much better on the actual situation on the ground. But I would just like to highlight that the Rohingya are in a real difficult situation. And I thank MedGlobal for the stellar work that they are doing in the camps. Thanks so much.
Thank you so much, Azeem, for all of that really critical context. Next, we will hear from Dan Sullivan. Dan is the Senior Advocate for Human Rights at Refugees International, and he focuses on Myanmar, Sudan, South Sudan, and other areas affected by mass displacement. He has more than 17 years of human rights and foreign policy experience, previously working with United to End Genocide, formerly Save Darfur, the Brookings Institute, Human Rights First, and the Albright Stonebridge Group, where he assisted former Secretary of State Madeleine Albright in her role as co-chair of the Genocide Prevention Task Force. And Dan has a master's degree in international conflict management from the Johns Hopkins University School of Advanced International Studies, SAIS, and a bachelor's degree in international relations from Harvard. Thank you. Over to you, Dan.
Great. Thanks, Kat. Thanks to all my fellow panelists and to Azeem for that introduction on the Rohingya. I want to talk a little bit about some of the experience I've seen and what what I've looked into in the camps, and then touch briefly on a broader report that Refugees International did on COVID-19 and the displaced. And so just to start off, Refugees International, we're an independent advocacy group based in Washington, D.C., but we travel around the world and talk to displaced populations, people working with them, and try to work towards solutions. And I've been covering the Rohingya for several years and have traveled to the camps in Bangladesh as well as in Myanmar and visited in Malaysia and Thailand. And have visited the camps in Bangladesh, including ahead of the August 2017 mass exodus and in the few days when that first started. So just wanted to reflect a little bit on what I've seen in the camps, and then again get into the some of the broader implications in what I've seen. I think it's important, and I'm glad that Azeem started off with the kind of the background on the Rohingya, because while I think we're going to focus in on on Bangladesh and the camps, I always try to make sure to emphasize that we have to all recognize that the root causes and the ultimate solution lie in Myanmar, in Burma. That's where the persecution has come from. That's where the ultimate solution we all want to see is that they can go home safely. But the reality is that there are some 600,000 Rohingya who are still in Myanmar that are facing persecution. The situation has not improved to where it actually would be safe for the Rohingya refugees in Bangladesh to go back at this time. So it's premature to really talk about repatriation. But that said, where the roots are in Myanmar, that doesn't mean that when we see that there are restrictive policies happening in Bangladesh that are unnecessarily making life more difficult for the refugees there, that we don't speak up. And so that's what Refugees International and partners have tried to do. On my last visit, and I had a report come out in February that highlighted really the lack of empowering, engaging, informing Rohingya refugees. And so that was happening before COVID-19 hit and has been threatening. And that's, that's really already those restrictions have held back with the response and the preventive measures that are going forward. And that includes including Rohingya refugees and everything from high-level conversations or global conversations about possible repatriation to just everyday life in the camps. And in particular, trying to empower the Rohingya refugee civil society that has been trying to grow. There's been, particularly since August of last year, for various reasons I won't go into now, there was a real shift towards more of a security lens that the government of Bangladesh was looking at the Rohingya refugees through. And that led to several new restrictions. So that was, a crackdown on the use of phones, on the mobile and internet networks, the beginning of building fences around the camps, which has really eroded trust among the community. And as I mentioned, just holding back, the ability of civil society to flourish. And so when you have COVID-19 threatening, that has some very real impacts. And when you have lack of trust and you have all kinds of rumors going around the camps about what COVID-19 is, about, various surveys have been done where refugees are saying it only happens to bad Muslims, or if you get it and you report to the authorities, they're going to kill you because there's no cure, or things like that going around. And really an inability to counter those, lack of trust to do that. And then just the basic education about what's going, what are the dangers of of COVID-19 and what can be done to prevent, and what and the ability to report if there are cases in the camps, really held back, especially by that the restrictions on the phone and mobile networks and on civil society. So that's kind of where things are in Bangladesh. I want to now just quickly look at what the more global scenario, and then what that means in Bangladesh in particular with the Rohingya. So Refugees International, we work around the world, and so we collaborated in looking at what are the threats of COVID-19 to displaced populations around the world, who are among the most vulnerable to the spread of COVID-19 and the effects that it will have. And we found a few common kind of underlying vulnerabilities that we highlighted, and then some common recommendations. So, among the vulnerabilities, obviously, there's the population density in camps. And, in Bangladesh, there's population density that's 4 times that of New York City. So already the idea of when everyone talks about isolating and social distancing, that's really, really difficult to do in a situation like that. The other thing is, just before this even hits, there's a lack of the basic services and healthcare. And so when you're talking about COVID-19, and even in the wealthy, healthy economies where there's a stress on finding respirators and masks and testing kits, that's just multiplied when you have these underlying issues. And on top of that, just there's different kinds of health issues that are more widespread in these camp situations. And then another one is lack of information, and that exactly goes to the in Bangladesh is very glaring with the the restrictions on internet and phone. So if you don't have that reliable information, that obviously holds back the response and the ability to prevent. And then the last 2 common kind of vulnerabilities is the reduced humanitarian supply chain. So obviously, as governments understandably restrict that access, that's going to cause disruptions that are going to affect those communities. And finally, the financial resources, when you're competing against something like this. And so that leads to some common recommendations, and I won't go through all of them. They're available on our website and our report on COVID-19 and the displaced, but just to highlight a couple. One is the response must be inclusive. And so Rohingya refugees, for example, in Bangladesh must be included. They are the front lines of this now, and you need to get equipment to these. And that's not, not rocket science, but it's something that has to be extra emphasized, and particularly when you have resource constraints, the people who are going to be on the front lines getting personal protective equipment and things like that. And then finally, again, the enhancing communications, and ensuring that there's reliable information going on. And that just to not, I don't think it can be reiterated enough that in the camps, that's what should happen first of all, is just lifting those mobile and internet restrictions, because there's enough challenges without creating new ones unnecessarily. And then I'll just end on what our report, the Refugees International report, ended on, and just the fact that we can't forget the most vulnerable. The virus does not respect borders. It doesn't discriminate, and any truly effective response, not to mention a morally correct one, also cannot discriminate. Thank you.
Great. Thank you so much, Dan. That was incredibly informative, and it's so useful to hear more about Refugees International's report. Next is Dr. Miriam Mola, who is a Bangladeshi physician serving as the field coordinator for us at MedGlobal in Bangladesh. And she has more than 2 years of experience working on the humanitarian and health response to serve Rohingya refugees in Coxs Bazar since the influx in 2017, and has worked with various national and international humanitarian organizations. Dr. Mola has a postgraduate fellowship in migrant and refugee health, and she represents MedGlobal at the Health Cluster and various intersectoral working groups in Coxs Bazar. And you can go ahead, Maryam, while I just share my screen and your PowerPoint presentation.
Thank you, Kat, for the introduction, and thank you to Dr. Azeem and Dan for the introductions on the background about the Rohingya refugees and the context in which us humanitarian healthcare workers are actually working and functioning. MedGlobal has been in Bangladesh since 2017. Next slide, please, Kat. Has been in Bangladesh since 2017, and during this time we have successfully provided services to over 112,215 patients through consultations. We have also, in addition to this, trained over 188 midwives, nurses, and doctors in life-saving resuscitation skills, known as helping babies breathe. Next slide, please. Just to provide a context of where we are working right now, in addition to what Dr. Azeem and Dan were mentioning before, in Coxs Bazar, it is estimated that 1.24 million people are in need of humanitarian assistance, with over 913,000 of these individuals being Rohingya refugees living in overcrowded camp settings. To contextualize what overcrowded means, every square kilometer of the camp has over 40,000 refugees living together in bamboo and tarp shelters. It is also estimated that over 30,000 of these refugees are aged more than 59 years, which constitutes the most vulnerable age group when it comes to the COVID-19 infection and disease spread and severity of illness. Next slide, please. So far, to date, there have been 6 positive cases in the host community in Coxs Bazar. That is Bangladeshi individuals who have tested positive for COVID-19. In addition to this, there are 447 Rohingya refugees in institutional quarantine facilities. These are the individuals that Dr. Azeem mentioned previously, who were in the sea for 2 months, and not having received assistance from any sources before they were returned back to Bangladesh and brought back in quite dire conditions. There have been no positive cases identified among the Rohingya refugees as of 21st of April 2020. This is primarily due to a limited testing, availability of limited testing. Only 20 tests were conducted in camp, and if you remember, there's 913,000 individuals, of whom only 20 were tested. In total, in Coxs Bazar, as of this week, there are 1,200 test kits available for a population of 2,289,990 Bangladeshi individuals, in addition to the Rohingya refugees that we are already speaking about. Next slide, please. So in order to deal with the COVID-19 pandemic, the health response is being led by the health sector, by WHO, World Health Organization, in coordination with the government of Bangladesh, the Refugee Relief and Repatriation Council, working in collaboration with UN agencies, national and international non-governmental organizations, including MedGlobal. This response is based on the following 9 pillars: coordination, planning, and monitoring, health risk communication and community engagement, surveillance, rapid response and case investigation, point of entry, district laboratories, infection prevention and control, case management, essential health services, operational support, and logistics. So coordination, planning, and monitoring. Next slide, please. In terms of the coordination, planning, and monitoring, the following health response strategies have been implemented. The health response strategy includes both public health measures as well as individual case management. In terms of public health measures, there has been declaration of critical phase in the humanitarian response, and there is scaling down of the humanitarian services to provide only essential health services in camp. Social distancing measures have been implemented at distribution points where the refugees go to receive their daily rations. These measures include reducing the number of days on which distribution happens, as well as allocating a predetermined rations, providing a set of food items with measured nutritional values, which are being delivered to some of the refugee households through community volunteers. There is enforcement of quarantine measures and risk communication messaging on hygiene, infection prevention and control, and COVID-19. It has been determined that it is vital to continue essential health service delivery. But as I mentioned earlier, this is being scaled down from what was being provided earlier this year to minimum initial service package, to providing only emergency, outpatient, sexual and reproductive healthcare services. Next slide, please. In addition to this, 2 quarantine facilities have been set up in Ukiah and Teknaf regions, which are the 2 major areas where the camps are located. In order to increase the isolation bed capacity in the camps, there are 5 severe acute respiratory tract infection isolation treatment centers being set up, each with 200 beds. And these are going to it is planned that there will be additional oxygenation support accessible to the Rohingyas through these isolation facility units. ICU capacity prior to the pandemic was very, very limited in Coxs Bazar. This, in order to mitigate and deal with critical cases, the Coxs Bazar District Hospital is being strengthened through the addition of 18 ICU beds and ventilatory support. Next slide, please. There are some key considerations. I will be reiterating what Dr. Azeem and Dan mentioned in their portion of the webinar, which is when forming health response strategies, it should take into consideration the perceptions on healthcare, the cultural values, and the health literacy of the Rohingya refugees, and especially when it comes to isolation, treatment, and management of dead bodies. The Rohingya refugees had very limited access to health services when in Myanmar, as well as limited access to education, and therefore their health literacy is very different from the literacy in other settings or more advanced settings. And therefore, any treatments or isolation or any health response strategies should take into consideration how they view, for example, isolation, and what kind of measures need to be put in place so that they actually utilize these services instead of avoiding them. As was mentioned earlier, there have been rumors about them not receiving services in facilities out of fear of being persecuted, but these things need to be taken into consideration. And therefore, there is an ongoing process of conducting focus group discussions with representatives from the community to make more informed, community-informed decisions for the COVID-19 pandemic response. Additional considerations are that scaling down of health services will have an impact on the pre-existing mortality and morbidity burden in the camps, especially on maternal and child mortality, as well as morbidity and mortality from vaccine-preventable diseases. Some of you may be aware there have been several outbreaks of diphtheria, measles, cholera, chickenpox in the camps. And on this context, when the COVID-19 cases are hitting the camps, it will have an impact, and therefore it is essential to continue to provide the minimum services that are required to maintain the current health status of the Rohingya refugees. Next slide, please. The government of Bangladesh, as a part of the public health measures and to mitigate the COVID-19 pandemic, enforced strict public health measures such as social distancing, and by implementing countrywide lockdown. For this purpose, they had deployed the military and other law enforcement agencies, and they're utilizing technology such as QR-coded tracking systems for vehicle movement. This strict restrictions on travel has an impact on the access to the camps by humanitarian agencies and humanitarian actors, and this requires strong advocacy on the part of WHO, UN agencies, and the international community to allow for the humanitarian actors to continue to access the camps and provide the minimum essential services for the Rohingya refugees. Next slide, please. And finally, as was mentioned previously as well, the lack of 3G and 4G networks resulted in a lack of access to information and communication about the COVID-19 pandemic for the Rohingya refugees. Even as far as into March 2020, the community was relatively unaware of the pandemic that was raging through the world. So this limited access to information definitely has an impact on the way information is received and understood by the Rohingya community as well. Similarly, for healthcare workers and health actors who are working in camp, coordination of referral processes, the screening, identifying and referring of suspected COVID-19 cases from within the camps to the designated isolation facilities cannot continue to run smoothly if there is limited access to the mobile networks and internet services for the healthcare workers as well. So it is essential that these matters be taken into consideration as we continue to move forward with responding to this crisis. Next slide, please. Some of the main challenges from a healthcare perspective and healthcare case management perspective on responding to the COVID-19 is a limitation in the supply of oxygen in the camps, and not just in the camps, but in Coxs Bazar region in Bangladesh. Personal protective equipment, keeping in line with the global shortages, there is also significant shortages and limitations and access to personal protective equipment for healthcare workers as well as non-healthcare workers, such as community volunteers who are engaged in providing services at different points within the community as well. And finally, there is a lack of human resources, partially due to stigmatization of COVID-19, as well as an inadequate supply of PPE, which makes healthcare workers hesitant to be frontline providers when there is a risk to themselves as well as to their own family and community members. So that concludes my part of this session. Thank you so much, Kat, and thank you so much to MedGlobal for giving me the opportunity to serve the Rohingya refugees for this long, and we hope that our viewers and everyone else will keep the Rohingya refugees in mind as this pandemic continues. Thanks.
Thank you so much, Dr. Maryam, for this incredibly comprehensive overview and all of your incredible work. We really just can't say enough about you. And then finally, to close out this panel, we have Dr. Sean Truelove, who is an assistant scientist at the Johns Hopkins Bloomberg School of Public Health in the Department of International Health. Dr. Truelove's work mainly focuses on vaccination impact and understanding the potential for outbreaks in various settings, including those of vulnerable populations. His research involves infectious disease dynamics, modeling, and methods development. He also works on pandemic preparedness and outbreak response preparedness as part of the READY project. He holds a BS and MPH from the University of Wisconsin-Madison and a PhD in epidemiology from the Johns Hopkins Bloomberg School of Public Health. And prior to coming to Hopkins, he worked for the Wisconsin State Health Department and then for the U.S. Center for Disease Control and Prevention in Cairo, Egypt. Dr. Sean.
All right. Hi, everyone. Thank you very much for all that amazing information and really setting the stage for, I think, what I'm going to talk about here is really getting into the numbers a little bit about the potential impact in this population. And really the purpose of this analysis and the report that we put out was to draw attention to the really massive impact that this emerging pandemic could have and probably will have in the Rohingya population as well as other refugee camps around the world. And so really, I think like many modeling studies that you might be seeing lately in the news and elsewhere, it's not necessarily correct, right? We're trying to get the best sense of what might happen under a set of assumptions. But what it does do is it gives us some numbers with which we can ask for help. We can encourage policymakers to make decisions. We can ask for money, and it gives us a sense of how much planning we need to do. Next slide. So really, so we focused just on the Kutupalong Bulakali expansion site of 600,000 people because it's a nice closed population, which makes the modeling efforts a little bit less complex. We don't have to worry about mobility. And we did a bunch of research in calling with UNHCR, MSF, and the other organizations to get a sense of just what the hospitalization capacity is within this population setting. And I guess not surprising to most of you, it's quite small. We found there are probably about 340 beds, potentially 630 surge capacity. And I'll get into why that's important to know and what that means for this pandemic. And we used an SEIR model, which is a mathematical compartmental model, where we basically assume people are within these compartments. So they start off as a susceptible individual, they become exposed to an infectious individual, and they move to the exposed incubating state, and then they become infectious, in which they can infect others. And eventually they move to the recovered compartment, where they are most likely immune to further reinfection. And because we're not trying to really do forecasting, we're not trying to really predict exactly what's going to happen, we decided to focus on scenarios instead. So we focused on low, moderate, and high transmission scenarios, where the moderate is really what we're seeing in many of the countries around the world in terms of the amount of, or the rate of transmission. But the high transmission setting is probably, as you'll see in the figures coming up, it may be more appropriate for this setting because of the high density of the population, the large household sizes, the difficulty in reducing or increasing personal space. And so we based this off of some analysis we previously did with the diphtheria outbreak in this camp setting, and the comparison of that transmission rate to what was previously seen in other outbreaks. And then an important component of this analysis was adjusting for age. And you know, everyone knows now that older people are much more likely to have severe infection and be hospitalized, potentially die, than younger individuals, which is somewhat different from what we see with influenza and some other diseases. And that really plays into what's potentially going to happen in this outbreak because of the young age of this population. And as mentioned before, we didn't yet consider, at least not during or with this analysis, we didn't consider any sort of interventions or control or behavior change because it is so challenging in this setting. You know, the stay-at-home policies, the isolation efforts that have happened elsewhere are really challenging in a setting like this, and they're challenging to do well. I'm not saying that they're not possible, but for this analysis, we wanted to avoid that and just focus on what is the worst case scenario, and then let's move forward from there. Next slide. So I mentioned age has a big impact on severity. So what we did was we took what we know about the probability of severity by age and the probability of death, and we applied that to the age distribution of this population to really get a sense of how much that's going to change what we might expect to happen. So in the top left with the purple, green, and yellow, those are the age distributions of this camp, Bangladesh as a whole, and China. And you can see that this those bottom bars are much longer for the younger age groups. And then if you look down at the plot below that, those age groups are the ones that really see very, very little severe illness. So hopefully that plays out in the same way in this population. We are making the assumptions here that this population will experience that in the same way, and we don't necessarily know that that's true because of some of the other underlying conditions. But we're hoping, and the evidence right now is pointing to that being the case. And so this all leads to this right plot here, which is the overall proportion of infections, not cases, infections that will likely be severe cases. And generally speaking, when we talk about a severe case, there's an official WHO definition. These are the individuals who require hospitalization. But you can see, the Italian outbreak that I think people are quite aware of now, which was quite severe. They have a very old population, and so that contributed heavily to that severity. hopefully this age distribution in this population will help the situation and reduce the overall burden. Next slide. So with this model, we get these projections. I'll walk through these pretty quickly, but basically what we're doing here is the green is a low transmission scenario, and that looks somewhat like influenza. The blue is a moderate transmission scenario, which is, like I said, what's been seen in China and the US and Europe. And then the red is this high transmission scenario, which I think is probably more likely in this camp setting. And these plots here, the darker line in the middle of them is the mean, the average epidemiological curve of cases or of deaths or hospitalizations. And the shaded area are the confidence intervals. So, but you can pretty clearly see that as soon as this really gets into the camp, it'll take a couple weeks. We will see a rapid increase in infections, most likely. Again, this is not assuming any behavior change or any interventions, but given that none of those things occurred, this is what it would likely look like. Hopefully some of these interventions will flatten the curve, as everybody's saying, and reduce this and maybe get us closer to that blue, maybe even that green. But I think it's important to understand the potential worst case here too. Next. And so from all of that, we get some of these estimates. So I'm not going to walk through all of these, but you can see in the fourth column, the total hospitalizations of severe cases are massive. We're talking 20,000 individuals over a couple months span. The number of deaths is high, 2,000 or so, which is, I think, some people have been surprised with these numbers being actually somewhat low. But again, that is largely because of that age distribution of the population, and hopefully these estimates are going to be correct. Again, we're not accounting for some of the other underlying conditions that we really don't understand how they interact with COVID-19 disease. But hopefully, the age distribution of the population will contribute to reducing the burden of disease overall. The next, actually the second to last column here is an important one as well. So one of the challenges with COVID is that it overwhelms health systems very rapidly. And I mentioned that this population has about 340 beds that they likely have serving them. So you can see these numbers here. These are the peak hospitalizations, and then the next column is the peak hospitalization capacity needs. These are well over what we need. And if you want to do the next slide, that dashed line in this plot on the left is that hospitalization capacity, the current, or the capacity at the time that we did this analysis. So each of these scenarios, even the low scenario, clearly surpasses that hospitalization capacity very quickly. And it does so and remains much higher than that capacity. So those death numbers again also do not account for the fact that or do not account for the occurrence of overwhelmed or surpassed capacity of hospitalization. So the potential impact may be much higher. So this is kind of the message that we wanted to get out there to really spark organizations to make plans, to find funding, build additional hospitalization capacities, plan with the national government how they will deal with shifting patients around. Because we do know that as soon as a crisis like this happens, a national government is more likely to use their own resources for their own population. And a population like this will get even worse treatment in a setting like this than they already are. So I think this kind of highlights the real challenges that we face that everybody's been talking about and put some numbers behind it. And that was kind of what we are trying to do here. And I think that's it.
Great. Thank you so much, Sean. This is such an important report, and it's really great to hear about it in more details. Over the next 10 minutes, we're going to try to get to as many questions as possible. And so I'm just going to kick it off with the first question that came in, which is for Dr. Mola. How has the engagement of international organizations like the WHO supported the health response activities going on? And given the current travel and health restrictions, how have the services they provide been disrupted? How are you working to compensate for that on the ground?
Okay, thank you for that question. International organizations like the WHO and the UN, so the WHO is leading the health sector in collaboration with the government of Bangladesh, Ministry of Health and Family Welfare, as well as the Civil Surgeon's Office. So they are, and in addition to WHO, the Intersectoral Coordination Group is acting as liaison and advocacy platform for the humanitarian actors to continue to provide services in the camps. So as I mentioned earlier, for example, when extreme lockdown measures were put into place, many humanitarian actors were actually not able to access camps due to restrictions, as well as vehicles being turned away for like relief vehicles being turned away, humanitarian actors not being able to go into camp. A strong advocacy on their part has gone towards mitigating some of these issues and easing the process. In addition to this, international agencies have stepped up to support, for example, the implementation of the QR coded system. There are many services that were disrupted. For example, protection sector services, which is heavily reliant on community health volunteers to provide services for survivors of gender-based violence, for example, has been significantly impacted due to restrictions of movement on, for example, community health volunteers. Similarly, many other services such as adolescent-friendly services, even basic necessities such as accessibility to distribution points for like e-voucher based distribution to food and nutrition rations has been scaled down and reduced in number. So that has an impact on the daily living of the Rohingya refugees, in addition to impacting the way that humanitarian aid workers are able to provide services in camps. I hope that answers your question.
Great, thank you, Maryam. The next question for all of the panelists is, what recommendations do you have for what else should be done locally to protect the residents in the camps? So if anyone wants to kick that off.
I could just jump in to start, just to again, I said this before, but reiterating the lift barriers that are not needed, so the restrictions, so that the needed information can get out there. And then the other thing is to try to provide personal protective equipment. One thing to highlight, which was encouraging to see in the camps, is that there have been Rohingya civil society groups that have been sewing masks and getting prepared. So any way to support those refugees who are on the front lines of this to prepare, that's what I would highlight.
Yeah, I would second that. I think we're learning more and more about what types of interventions work, and how much these things like social distancing and masks and things can really reduce that transmission. And in a setting like this, I think, yeah, personal protective equipment, masks, are really going to be critical. And it's that challenge of we just don't know who's infected. So things like isolating cases, it just doesn't work when you have 40% or 60% of the the infected individuals not showing symptoms. So we really want to prevent people from transmitting, and by having them wear masks, that's how we prevent further transmission, or at least reduce it.
There are, for example, plans in place right now for like point of entry was one of the 9 pillars, which is to provide hand washing stations at the points of entry and exit to camp for the humanitarian actors. Similarly, when the refugees are going to the respective distribution points or healthcare facilities, there are procedures and plans which are being put into place to improve the infection prevention and control, as well as hygiene measures. However, there is still many limitations and restrictions to this. For example, accessibility to running water is in the camps is very limited. Majority of the Rohingya refugees are reliant on hand pumps, and washing your hands at a hand pump is not as easy or as feasible as when turning on a tap. Again, there are efforts to address these issues as well through providing jerry cans with faucets, for example. But again, coverage of these services is variable and limited by many of the restrictions that are already in place, as well as the acceptance and acceptability by the Rohingya community as well.
I think the only thing that I would emphasise is that the government of Bangladesh lift the internet restrictions, the Wi-Fi restrictions. Information is absolutely critical in this situation. And at the same time, I would also emphasise to clamp down on some of the propaganda that's being perpetuated by a number of groups. Very recently, I had a conversation with a Bengali citizen, and I just brought this up in a conversation. And his attitude was, which is shared quite widely in Bangladesh, well, we don't really care if these people get infected. They shouldn't be here in the first place. They are such a huge burden on the state of Bangladesh. You know, these people, this refugees camp is costing $900 million a year, and the world now has donor fatigue. So the attitude is that, well, they shouldn't be here. So if they get infected, a few of them get wiped out. It's not a big deal. But the reality is that if this virus manages to get into the camp, you know, it's very unlikely it'll actually be restricted there. More than probable that many of them will leave. You know, as anybody would do in that situation, if you hear that there's a virus in a confined space, you try to leave with your family. So what the implications of that for not just Coxs Bazar, for the rest of Bangladesh, could be quite dangerous. So I would suggest that they try to clamp down some of the misinformation that's being perpetuated by various groups.
And then just for the sake of time, I think we're just going to take 2 more quick questions and then have some just quick closing remarks from all of our panelists. So this question is for Sean, but if anyone else has thoughts as well, please feel free to jump in. So the question is, shielding for the elderly as the most vulnerable has been proposed as a way to mitigate the effect of COVID-19 in camps. Given the practical constraints in setting up such mechanisms, should shielding not be possible, what kind of actions should humanitarian actors take? This is also keeping in mind that capacity of isolation and treatment facilities remain limited. So that's question number 1. And then number 2, a very tangible question. If any of the panelists know this specifically, where are the hospital beds located? Is it in or near the camps or in Cox's Bazar town?
All right, so in terms of shielding, yeah, I know it's been talked about a lot lately, and it has definite merits. I worry that it's a very difficult thing to do correctly. And you know, they tried to do this in France, and everybody who was shielded ended up getting infected, and it was a nightmare. So what kind of actions that humanitarian actors should take? I think figuring out how to prioritize individuals who need care the most is important. And all the things we've been saying, communication, reduction of contact, increasing personal protective equipment, things like that. So open it up to everyone else.
Just jumping to the second question, does anyone have any knowledge of the locations of the hospital beds in the camps or in the town more broadly?
Yeah, I can speak to that. There are 257 isolation beds which have been allocated within the camp itself. So there are many primary health centers with inpatient, 24/7 inpatient capacity of, and the beds are not 257 beds are not within the camp. It's like within one facility, but rather spread out throughout different locations in the camp. In addition to this, there have been beds allocated in the two Upazila health complexes, which are the two local county hospitals, and then beds have been allocated in the district hospitals as well. In addition to this, there is plans to increase bed capacity for the surge by constructing 5 200-bedded facilities. So the plan for now is to increase the total bed capacity up to 900 beds, which can serve as isolation facilities for moderate to severe cases. And for the critical cases, there is an allocated of 18 beds in the Coxs Bazar District Hospital, which is 1.5 to 2 hours drive away from the actual camps.
Great, thank you, Miriam. And we're right at 11 right now, but if everyone doesn't mind just going a few minutes over, I would love to hear any closing remarks from the panelists, particularly knowing that a lot of the attendees who are listening in are based in DC and New York and involved in policy. It would be great to hear closing remarks, and particularly with an eye for recommendations that you would have for either the US government, UN stakeholders, or other key government stakeholders. And just an FYI for all of those attending, I've also taken down the remaining questions that we didn't have a chance to get to, and we'll be able to follow up with you individually to answer those questions. So if we could kick it off with any closing remarks from Azeem, then Dan, Maryam, then Sean.
Well, I can start off. The only thing I would say is what I emphasised earlier is that is to ensure that the personnel on the ground have the kind of capacity that they need. I think one of the key learning lessons that has emerged out of this crisis is that these huge international global humanitarian organisations simply do not have the wherewithal to actually operate on such a local level. And I think one of the changes that we'll see coming out of this globally is that there needs to be much more of a local kind of effort to support local organisations to actually carry out the work, organisations that are on the ground rather than trying to import them from elsewhere. So I think groups like MedGlobal and others that are operating on the ground should be given the kind of facilities that they need and the capacity that they need to actually carry out the work rather than relying on these huge international NGOs, whether it's the UN or the World Health Organization or something, because they simply are simply not nimble enough to move in such a crisis. So I think that would be my key recommendation, is to support local efforts, local organizations that are operating on the front line rather than wait for the larger ones to get their act together.
Yeah, just first to say thanks to MedGlobal and my fellow panelists and everyone for tuning in. For my final comment, I'll reiterate something I saw in the webinar chat from somebody who's on the ground and has been on the ground and who I know is very knowledgeable about this and efforts there. But the last thing she said was the role of refugee community leaders and groups is very important, and just re-emphasizing battling this lack of trust and that some of the community members have, and those rumors that are going around, and just the importance of building that up. And I know there are some some important efforts that IOM and others have been doing to try to better survey the community and to identify some of the false information that's there and come up with recommendations for how to better engage and build trust with the community. So I'll just leave it on that it's kind kind of going off of Azim's point as well, just that local aspect is really important. Thanks.
Thank you, everyone on the panel, as well as for the great questions that came in. As the closing remarks, I just want to say that it is important for healthcare workers also to continue to be empowered to be able to respond to this crisis through additional trainings, through the provision of personal protective equipment, through the just even addressing, for example, their mental health needs. And this, obviously the needs for mental health services for the Rohingya community will also be increasing in response to this pandemic as well. So these are just certain sort of cross-cutting issues that do need to continue to be addressed and need to be prioritized when responding to this pandemic internationally.
And yeah, thank you, everyone. I've learned a lot actually from this. But I think my closing remark is that this is a global crisis, and I think it's been easy for people to forget about some of these populations because they're being affected themselves. And so I think we need to make sure that these populations are not forgotten by funders and by the general population while they're facing their own crises at home. And it kind of it emphasizes the importance of continuing these efforts and these relationships with people on the local level and internationally. And so I think hopefully there's positive things that can come out of all of this as well.
Great. Well, thank you so much for the four of you for being, humanitarian and health leaders and leaders in this response and sharing your very insightful remarks. And thank you so much to all of the attendees for joining. One thing that has been highlighted in this panel in particular is the shortage of PPE, of personal protective equipment, all over the world, and particularly in areas like Coxs Bazar in Bangladesh. So one thing we would love for you to consider is to support our urgent COVID-19 response. We are responding in Bangladesh as well as Gaza, Syria, Yemen, and Pakistan by providing PPE, including masks, gowns, gloves, and eye shields. And our goal is to sponsor 2,500 health workers. So I would encourage you to check out medglobal.org and consider joining us in this effort. So thank you so much to everyone. And I hope that you all have a good rest of the day and week. Thank you.
Thank you so much, Kat. Thanks so much to everybody.
Thank you very much.